Thank you for joining and having me here. I am used to talking to mostly moms, and I'm sure there are many of you that are moms as well, but it's nice talking to an audience of you as hospital liaisons and for what you do. Um, it's a different angle for me, so bear with me. I wanted to kind of briefly say what is the connection between my role and your role in this. And so, as Jennifer explained in my bio, my role in my therapy practice has been primarily to witness and see and support postpartum moms, especially those who end up getting diagnosed with depression or anxiety. And I hear stories about their labor and delivery, difficult trauma that sometimes happens during their hospital stays, but also mostly stories about wishing that they would have known the signs or gotten support earlier. And so I see, this back end of women who've been struggling usually for months before they even seek help. Your role, as far as my understanding, is that you guys see the postpartum moms immediately after, before they even leave the hospital, and honestly, likely before they even show signs of any postpartum depression or anxiety. And you're trying to convince them that they're going to need support. Um, and I see the regret that women have if they don't get the support. So, in essence, I think we're two sides of the same coin, right? Like we, I'm on the treatment side on the back end, you're on the preventative side on the front end, which is why I kind of thought of you guys as I heard about your program, and what your important role is, as you guys are on the front lines. You're there immediately. And I think I'm hoping through this presentation, I can give some insight and tips about how to better equip you to support and help some of these at-risk moms on the front end, and hopefully minimize some of the suffering that many women experience before they end up coming to me when they're really suffering. So that is what my goal for today is. Um, I'm going to be referring a lot to um, perinatal mood and anxiety disorders, and I'll go over what that means in a bit. But as we talk today, I thought it would be helpful just to show you, like, what are we talking about when I'm talking about the mental health of a postpartum mom? What exactly does that mean, right? And so these are common symptoms that are troubling, right? We can talk about mental health in a positive way, right? And we can talk about mental health in a debilitating way. And so as we just converse today, and I'm talking, when you are looking out for signs or talking to women about their mental health, these are some of the most common symptoms that can become debilitating for them. So I just kind of wanted to put those out there so you'd have an idea of what I'm talking about. So women who feel totally overwhelmed, they're very weepy, anxious, nervous, very irritable. They're scared by their own thoughts. They might say things like they don't feel like themselves. They're in a mental fog, like a cloud over their head. They experience guilt, regret, shame. They're confused, sleep issues, and eating issues, loss of appetite, and difficulty focusing. So these are some of the common ones, and I just kind of wanted so we could have like a language around that. Okay. The other question I get a lot is, and that moms have a lot, are what is the difference between baby blues, that term baby blues, and postpartum depression, right? And so I kind of wanted to go over that because I think it's just helpful to know. For baby blues are a natural part of the post-birth experience. Like it's a pretty universal experience of just your hormones just getting restabilized right after birth. It usually starts 2 to 3 days after delivery. So probably actually around the time that you guys are coming in to see them. They last up to 2 weeks. So not very long, but it's very normal. And it looks more like mood swings, anxiety, irritability, weepiness. Those, it kind of is contained to that. And after about 2, 3 weeks, it lifts and it's done. So it's nothing really debilitating to worry about. It's just kind of sucks to go through, right? um, on the other hand, perinatal mood and anxiety disorders are not natural, so to speak. Like we would consider them a disability. And something here. The onset is actually any time during the first year postpartum. So it can begin right after baby blues. Baby blues can move into a perinatal anxiety disorder or depression, or it can start like when the baby is 11 months old. The onset can be anytime in that first year. The theory is like that women's bodies take a pretty good year, not 6 weeks like maternity leave tells you, but a pretty good year of recovery. It varies per person. It can last, and a lot of this depends again if they're getting help, if they're getting treatment, a couple weeks or possibly months. And the biggest difference is that it limits daily functioning. So baby blues are just kind of, you go through it. It's a natural part of women's bodies. It can shift into a disorder when you cannot function. Either you're having a hard time taking care of the baby, or you're having a hard time with social relationships, or you can't go back to work, can't focus. So that's what the difference is there. Okay, so I'm throwing out this term, and I'm perinatal mood and anxiety disorders. It's a mouthful, so I'm going to be calling it PMADS. It's not just postpartum. So perinatal refers to all of the time of pregnancy, all the way to a year after giving birth. And it also includes, this may not be relevant to you unless you see women in the hospital who've had a previous infant loss and maybe have had postpartum depression in the past due to an infant loss. But women who've like had a miscarriage or stillbirth, or trauma and at birth, they're physiologically considered postpartum. Their bodies are still going through the same hormonal stabilization. It's also not just depression. You know, in the media and in TV shows, everybody calls it postpartum depression, postpartum depression. PMADS does not cover just depression. It also covers anxiety. And in fact, I see anxiety more than depression. Depression is kind of the withdrawn, shut out. The anxiety is a little more heightened worry state. There's postpartum OCD, obsessive compulsive disorder, that develops after the birth of the baby. So it's like it hadn't been present before, so it's a new thing. Postpartum bipolar disorder, typically that develops if the woman has already had bipolar, but you'd see sometimes in the postpartum period going into a manic state. Postpartum PTSD, post-traumatic stress, is typically related to if they've had birth trauma. And I'm going to refer back to that because it's pretty common. But if there was some kind of trauma during birth, like an emergency C-section or a threat to a loss of life, either the babies or the moms. And the most rare is postpartum psychosis. Again, you see that in movies and in the media, but it's actually less than 1%. And so I've honestly never even seen a case of that. So I wouldn't really worry about that. It's also, PMADS is not just contained to like affecting the mom only. It can affect the infant and their attachment to the mom, their development. It affects their family system. It can affect the parenting practices if it goes untreated. So that's what I mean by PMADS. Some statistics that are pretty sobering are 40% of pregnant women actually have symptoms of depression and anxiety, or those symptoms that I referred to you in that initial slide. That's a lot, and most go undiagnosed. 1 in 5 women will suffer from a PMAD. And again, that's a lot. Another interesting fact is 1 in 10 dads will experience a perinatal mental health disorder following the birth of their child. This is really not talked about as much, but 10% go on to have their own symptoms that often go untreated. And of the women who have a PMAD, only 15% actually seek treatment support for it. A lot of questions I get are about like, well, where does this come from? How is it caused? The etiology. What are the factors that would cause one mom to have it and one mom to not have it? So again, as everything, it's complicated. There are theories of there are absolute physical factors. For example, a woman might have a sensitive endocrine system, and in fact, so I don't know if you know this, like there's this huge hormone crash in the postpartum period within the first 48 hours of giving birth. So it goes from like your hormones are like at 200% and it's supposed to go down to baseline in 2 days. That's crazy, right? The body is supposed to restabilize, but they found that about 1 in 7 women's endocrine systems are actually more sensitive and are not as effective in establishing equilibrium, like going back to that baseline that fast. And so that is one explanation of women who might be more prone to developing a PMAD. There's also a genetic predisposition. If depression or anxiety or another mental illness runs in your family, you're more predisposed to getting something postpartum. There are also psychosocial factors. A lack of support system is a huge, huge factor in the possible development of a PMAD. And things like messages that our society gives about moms, the social myths that you're supposed to do it all and be perfect and be a superwoman, and look good while you're doing it, right? And like all these myths and that amount of social pressure can also contribute to a PMAD developing. And then there's just concurrent stressors that might be going on in the mom's life at the same time that are adding to their stress level. So sleep disruption, poor nutrition, other health challenges that they might have come in with, interpersonal stress. Maybe they don't have a stable partner with them or family to help them. So all of these 3 things together kind of put people at risk and is what we think is where we think PMADs comes from. Another question is, how long does it last? Of course, I'm going to say it's different for each person. Everybody's body's different, so it could do with how long your hormones take to rebalance. It also depends on if that person is willing to face what they're facing and to get help. And if they do get help, there are stages of recovery that can take a while. So for example, the acute symptoms, those symptoms that I showed you on that first slide, may take a couple weeks to resolve or a few months. Typically things might feel worse before they feel better. When I see women, they feel a little better because they're finally getting help, and we have a couple sessions and they're feeling better, they're getting some new coping skills, and then they start sliding back down. And they can have those off and on symptoms for like the entire first postpartum year. So it's not a straight line. I don't know if you've heard this, but like that saying that healing is not linear. It doesn't just go straight up like this. It's going to be up and down. And the advice is like, get support as soon as possible for it to not last as long. Women always come and ask me, well, how much therapy would I need for me to get better? Like I want an exact number of sessions, and it's hard to give it because it depends on if I'm being effective with them. If it depends on if they're applying what we're learning together. It depends on their support. It depends on so many factors. The general rule of thumb, though, is if you're committed to treatment, then it should take around 10 to 12 sessions, which maybe is like 3 or 4 months. So that's what I give as like a general rule of thumb if somebody really needs an answer to like sell them on it. I wanted to also point out just the magnitude of how severe and how complicated PMADs can be for our society. So up to 20% of maternal deaths are actually due to suicide, which makes it actually more common than deaths caused by postpartum hemorrhaging, or other health issues like hypertensive disorders. So it's one of the most, yeah, it's a huge deal. It shouldn't be that high. This slide shows that the majority of the pregnancy related suicides or postpartum occurs actually postpartum between days 43 to 365. So it actually does 62% occur later, not immediately after birth. Like only 14% occur within the first 42 days, which is like what, the first 6 weeks, right? And 24% during the pregnancy. But the majority is actually later on, which again just stresses the need to get support sooner rather than later to prevent it. And in fact, the CDC has come out and said definitively that pregnancy-related deaths from suicide are 100% preventable. That's a pretty bold statement, meaning we can help these women on the front end. I know you guys do your own screening, and not necessarily specifically for postpartum depression, but I wanted to show you what other health organizations and professional organizations recommend about screening as a preventative tool. And if you see this, none of these include screening in the 48 hours after delivery. So the American College of OBGYNs recommend 1 or 2 times during pregnancy, and then at that 6-week appointment, a 6 or 8-week appointment. That's what they recommend. And the American Psychiatric Association recommends 2 times during pregnancy and 4 times postpartum at the 1, 2, and 4-month well child visit, like at the pediatrician. Postpartum Support International ups it to a recommended 8 times, and you can see when that is. But as you can see, none of those times are the immediately after. So you guys are in this unique position because you're going to be the first people even asking or exploring their mental health. Okay, so my understanding of your role as hospital liaisons is, like I said earlier, I consider you guys like the frontline support. And that means that's important because for one thing, you're a non-medical presence. So you know these women. I know some of you are more experienced in this role than others. But you have like doctors and nurses and all these people coming in and out of your room. I have 4 kids. I have the whole gamut of my postpartum experiences in the hospital. And there's no way the mom can sleep because everybody's like checking their blood pressure, doing something, or then the cafeteria guy's coming, and then the janitor's coming, and and then a visitor wants to come, and so there's just constant stimulus. But you get a chance as a non-medical presence to offer some warmth, right? And offer some softness in this very clinical setting. I think I see your role as really normalizing the need for support, meaning the more these women believe that support is normal and necessary, I think the more you're going to sell them on the Welcome Baby Home program, right? A lot of women will have defenses up. They might have some pride. They might have some shame around getting support. And we're told, back to that social myths that I mentioned, we're told that we're supposed to be doing it all on our own. Like women are told, yeah, you pop out this baby, you go home, you figure it out by yourself, and in 6 weeks you go back to work and somehow figure out affordable daycare or something. And none of that happens. And so I think normalizing it as much as possible. sorry, I just thought of something. I'm going to tell you. When I started training for postpartum care, I read this great article. This is totally off topic, but I read this great article about how the incidences of postpartum depression and anxiety are much lower in other countries that have a more collectivistic culture, right? And so countries in like Africa and Asia, for example, this is not like we have 1 in 5, 20% of women suffer from this. Their numbers are like way, way lower. And the theory is it's because they've normalized the need for support. And they happen to be in a culture where the mom comes home into a village, right? She comes in back home, not just her and her partner figuring it out by themselves in the middle of the night. They come home to aunties and uncles and cousins and grandparents and all these people helping with the baby, helping this right, cooking, cleaning. The mom is like often lifted up and honored in a lot of these cultures, where in the US, like you're only honored at your baby shower, like before the hard stuff. um, and I just thought this was a great article and a great point to make. So I'm putting it out there because I think if we can normalize, like, hey, we were made to have support. We weren't made to have babies without support. And so here is an opportunity for support, right? I think your role also is meant to validate that this is hard. There is nothing easy about a whole coming into a whole new identity in a split second. You're seeing them like on day 2, and they've like never been a mom before. Let's say some might have other children at home. Doesn't matter. That can even be harder. Every pregnancy, every delivery, every new baby is a hard adjustment. And so I think validating that so they can hear that they're not going crazy. Their feelings make sense. Women just want to be told that we make sense, right? So also I see your role as just being that safe space for vulnerability, instead of sort of like that clinical person coming and jabbing you with something or taking your temp or that kind of thing, that you can just kind of maybe slow them down and help lower their guards. And then I know that your role is to screen these women for potential mental health risks, not to diagnose. So just to clarify that that's not your job. You don't have to figure out, is this depression? Is this anxiety? Is this PTSD? I more just wanted to give you an overlay of what the diagnosis could be eventually. But your job is just to do your screening, right? And then I see you guys as educators. Even if the education part is a little bit of what I'm saying now, or even if it's like, I don't know the answer to that question, but I know we have resources of people who do. And again, always kind of pushing for that normalization for support. Okay. I also just wanted to remind everybody that you can't tell just by walking in the room if a mom is struggling or not, or is a potential candidate for a PMAD. You can't. I mean, maybe it's obvious if you walk into the room and the mom's sobbing, okay, something's happening. But even then, you can't assume anything. And oftentimes, it's 48 hours after birth, if a mom might be on the opposite end, she might be on a high and excited and looking joyful, and she has like balloons and flowers and visitors and everything's happy. You still can't tell if that's what she might be masking either in that moment, or what other risk factors may be hidden behind the scenes that might develop into a PMAD. So I wanted to give like some sample lead-in statements or questions. I know you guys have it's called Bridges, right? Bridges assessment. But I thought that these, if you're figuring out a way to like how to soften the conversation, I came up with some of these lead-in statements and questions that you might want to consider. So one is like just saying, hey, was labor and delivery different from what you expected? what has been the hardest part in the last 24 to 48 hours? So one, these questions are already normalizing that their labor and delivery might have not gone as they expected, might have been traumatic, and that normalizes it. Like, oh, here's somebody asking a question that assumes that, oh, some people do have different labor and delivery experiences. By asking what's been the hardest part, um, again, you're validating that there must be something hard. So um, it opens up the door for a conversation in that way. Or you can just say a statement like, wow, you just went through a life-changing event. It is normal to feel overwhelmed and anxious. Like I know I would, or I did, you know. Or you can say something like, I know it's not easy being a new mom, and it's okay to feel unhappy or worried or confused, especially right after delivery. So again, these are just normalization statements. Um, the risk factors are really honestly, I'm going to kind of quickly go through that. This is the same as like the etiology. You know, the slide that I had of like, where does it come from? And the risk factors are basically the same thing, right? If a woman's endocrine system is off, which you may not know beforehand, if they have other health conditions, if they were a genetic predisposition to a mental disorder, the psychosocial, if they already know going in, you already know they don't have a support system, or they don't have a partner with them at home. Another psychosocial risk factor I wanted to mention is like the overachieving type A personality. Um, I see so many women who are that personality, like, you know, they have to have everything right, everything neat and in control, they have to have everything planned. And if you see that kind of mom with that personality, that is a major risk factor for postpartum anxiety in particular. Um, because she's experiencing a loss of control when she's used to being in control. And then environmental stressors that we've covered, economic, nutrition, maybe cultural stress or other barriers. I also wanted to give you guys some language to look out for. If you hear some of these statements, I would just encourage you to ask further, or just kind of make a note of like, oh, okay, this woman might struggle when she gets home. So if she says something like, you know, it's hard for me to ask for help, I take care of myself. Or if they indicate that in generally their menstruation, their cycles, they get sad, angry, cranky. They're more prone to getting a PMAD. If they talk about like I don't sleep, now I get in the hospital, nobody sleeps in there. But if they're saying like they have lots of running ideas, it's hard to slow down in general, that might indicate something in the future. And this one, I've not slept for at least 4 uninterrupted consecutive hours in days. That's more for the mom who's like already at home. So I know this might not be relevant to you. Because like I said, in the hospital, nobody is sleeping. Like no mom I know has slept for 4 uninterrupted hours in the hospital. But when they get back home, they should start. And if you find out that they haven't, I know this might not be related to your role. That is somebody absolutely at risk for a PMAD. If they say something like, I have scary thoughts that won't go away, like images that bother them in their head, or thoughts in their head about like bad things happening to their baby, that's one. They say like, my family's far and I'm lonely and I have no support. I don't have any friends nearby. That's showing that they are going to be isolated. If they indicate that they were not happy about their pregnancy, they didn't really want the baby, or if they indicate that they're worried about finances and shelter. Other major risk factors or clues, like if you're looking at their chart, like if you happen to see their chart ahead of time, that might kind of perk your ears up to like, oh, this woman might need some extra encouragement or extra push towards support, is if there has been a traumatic birth. And a traumatic birth, by the way, is defined not by anybody but the woman. So if the woman says, I had a traumatic birth, then you have to believe her, then she had a traumatic birth. And that can look different. So a woman who is rushed into an emergency C-section might consider that traumatic because it was this scary moment and loss of control of her body. And another woman might have gone through the same experience and not have considered that traumatic. So it has to do with what the woman says. Um, if their baby's in the NICU, that is another risk factor. They've been separated from their baby. Often, if it's a C-section, sometimes they might have just like glimpsed at their baby and not been able to hold them because they're on the table in the C-section and been immediately separated. And that kind of goes hand in hand with trauma, potential trauma. If they've had multiples, twins or triplets or more, I don't know. um, those are other risk factors. Just, I mean, hormonally, I have twins, and hormonally, you're even more out of control. um, and like, for example, with mine, one of mine was in the NICU and one stayed with me. And so it was kind of like a lot of factors going into that scenario. If you notice the woman is complaining of lactation difficulty, that's another risk factor. That's a major point I'm going to get back to in a different slide. Also age. So if you come across a teen mom, or an older mom who's already in perimenopause, for one thing, being a teen mom has its own um, stigma issues, but also her own identity issues. Perimenopausal woman who's on the older end is also going through their own unique hormonal challenges. So if you see ages like really young or older than normal, well, then those are risk factors as well. And then if you go in the room and there's no partner or social support, like if it's pretty obvious this woman's on her own. I wanted to give you guys some like words of reassurance that you can use if you're like kind of stuck, like maybe you keep this list in your back pocket or memorize it. Um, because I think it's really important. A lot of the goal, I think, for if you're seeing an at-risk mom is to just reduce her shame um, around hard feelings. Because we're told, be happy, you're blessed, you have a baby, why aren't you smiling? And so I think normalizing the hard feelings, reducing the shame, promote seeking help, that's what the goal here is. So saying something like, your feelings, like say she tells you during this assessment, I'm just so confused, I don't know what to do with the baby. Your feelings of confusion are completely normal following the birth of the baby. Just, it's normal, it makes sense. One, you're not alone. So many other women experience this. And connection and support is going to help you. Telling the woman you're not to blame. There's no wrong feeling. You're not wrong for feeling any of these things. This is not something you caused. Or even if they're asking you, what if I get postpartum depression? What if I get this? What if I get that? It's like, well, you won't be alone, right? You're not going to be alone in it. You're not to blame. And with help, you will be well. With treatment, all these symptoms are treatable. And it is a sign of strength to reach out. And life it'll get easier over time. Like kind of giving them that hope that this is not forever. And that you are enough and will be enough. These are just kind of good encouragements that can bring a new mom to tears and feel comfortable. So again, like I think there's so much power in prevention. Like I meet with so many moms who I'm like, oh, if only they got support at this point in time, if only they knew this piece of information. And so that's where I think you guys have a huge role in, for example, like promoting their physical recovery, making sure they know they need to sleep and eat well and take care of themselves when they get back home. Giving them those support resources and all those options that you guys have, like pushing that as like, if you're nervous about getting postpartum depression or anxiety, this is what's going to minimize that risk. This is going to help you. If you needed to give them some education about the warning signs of like what to look out for, you have that before they leave the hospital. And then similarly about possible treatment to seek. Um, quickly on breastfeeding, I know you guys, I was told you guys had a webinar on breastfeeding um, the last time around, right? And so this might be repetitive information, but I wanted to pull this out in particular because the timing in which you're seeing these women, um, that what 48 hours to 3 days, after giving birth, a lot of these women are already struggling with how to breastfeed. Um, they might have initial difficulties post delivery. Either they're having a really hard time understanding how to latch the baby, they're experiencing pain, it's new, it's confusing, they don't know the position. Um, there's also, I think, I I know you guys are all across different hospital sites. Um, I know in general there seems to be a lack though of lactation consultants in recovery. I think they're supposed to make the rounds, but as far as like the time spent and how often they're visiting, that can be limiting. And so then they just are like clueless. Like you could have taken a breastfeeding class before in pregnancy, but honestly, it's not, it's not the same as like actually having a baby at your boob. So, um, and overall, I think that some of these women might not even have the breastfeeding education. So if they're being told like you need to pump milk, you need to pump, and you need to do this, and you need to get the milk, and then their colostrum, they're only getting colostrum, the initial stuff before, and their milk doesn't come in usually till after they get home. A lot of women don't know that. They don't know that it's like 4 to 5 days after birth that like the actual white milk comes through. Like they just don't know. And so then they think they're doing something wrong. And then there is the role of birth trauma with breastfeeding challenges. So, for example, if a woman has experienced a lot of postpartum hemorrhaging, that can decrease the milk supply in the beginning. Or again, if there's a NICU separation, then that baby is primarily getting formula, and the woman might be pumping to give the baby colostrum, and then when the milk comes in, running to the NICU to give their milk. But if you're doing that, that can decrease your milk supply as well. I also wanted to touch on partner involvement. I had mentioned before about how many fathers in particular end up suffering and experiencing their own depression and anxiety symptoms. And I think if you can normalize that, I know if the partner is in the room while you're doing this assessment, I think normalizing that for them too, including them into the conversation, like, hey, it's going to be hard for you too. You might experiencing these same symptoms. Encourage the partner to look out for their own signs of depression or anxiety. And then there's this thing that I think is really interesting that's not really well known. It's called the second trimester of fatherhood phenomenon. So basically, they found that up to 25% of new fathers had depression during the 3 to 6 month postpartum period. So it didn't show up until months 3 to 6. And oftentimes the phenomenon is because the moms who maybe they got the postpartum depression sooner, say around the 1 or 2 month mark, they're getting help and they're starting to get better as soon as the dad, meanwhile, has just been holding it together. They've maybe had to take over a lot of the baby stuff. They've had to get the mom the help that she needs. And as they're just recovering, that's when the dads, they've seen this pattern, tend to just then start falling apart and experiencing their own debilitating symptoms. We're going to transition into this role play. How are we on time?
We have about almost 40 minutes, so we're able to do
Can I go through this?
breakout rooms, or if everyone here participates, we can do this together. Again, I want to use this time to learn from one another, collaborate, and so maybe there's a better option, but I don't know what you think, Jeannie.
Well, yeah, let's just try it as a big group and we'll see. I had 4 role play scenarios and wanted your guys' participation as far as like, what would you say to these types of moms in this scenarios? How would you connect with them? What encouraging things could you say to them? What approach could you take? Okay. So here are the four. I'm just going to briefly go through each four. And then we thought maybe you guys can vote in the chat, like just by number, which one or two you most want to like talk about first. So we don't, run out of time. But so I'm just going to give you a little preview for each one. So the anxious one, this is the mom. And for those of you who are like experiencing this, I'm hoping some of this will click to you. And again, these are absolute generalizations, right? I don't want to box people into just like this or that, but just for the sake of practicing wording and approaches we can use, I kind of broke it in that way. So number one, the anxious mom. That's like she automatically appears worried, she's restless, maybe fidgety. Maybe she's asking a lot of questions and you don't even know the answer. Like she's trying to like get you to answer questions about the baby. She might be trying to problem solve. She's fretting over the baby. She can either look like she's the most open to wanting support, like, yeah, I don't know what I'm doing, I need support, or the most distracted and not listening to you because she's like so worried about all these other things happening. So that's the anxious mom. Number two, the silent one is kind of your classically depressed mom. She might just like look really shut down, like blank stare, maybe giving you really short responses and not really engaging with you. She might be tearful or weepy, can't really explain why. It's kind of hard to like get stuff out of her. Number three, the I don't care one. This is maybe similar to the silent one as far as not really wanting to talk to you, but kind of more angry, like more annoyed that you're there. Like, can you just leave? Like, tired of people coming in and out of their room. They might kind of act tough, like, you know what, I got this. I don't need your help. I don't need your support. Go away. That's number three. And then number four, the traumatized one. This is the one that's least likely giving you outward signs. They might look like any one of these, and they might look anxious, silent, depressed, or I don't care, angry, or they might look perfectly normal. I would say the traumatized one is where you kind of see in their chart, or if you've asked about labor and delivery and you've noted, they've had a harder labor and delivery, or something unexpected or scary happened during the labor and delivery. And so they might be experiencing some trauma. So remember, that would be like, oh, that mom's baby's in the NICU, or they've had an emergency C-section, they have multiples. Then that would be a clue for you of like, okay, I might need to approach this one with care. So that's my like preview. Do we have votes?
So far, we have the I don't care mom.
Okay.
And we have the silent one, the I don't care mom too.
Mm-hmm.
I don't care, but
wow, the I don't care. Okay.
Yeah.
Should we just start with that one then?
Yeah, let me just give
I
them.
guess let's just start. Yeah, give them some time.
And see. Yeah, it seems like number three, number two, and number one are the most popular. Mm-hmm. We have a couple that we can see. And
well, this is where I wanted to hear from you guys. Either for those of you who are experiencing this, what do you do? What do you say, or what do you think you could say? And so we thought, if you want to answer in the chat, or I guess raise your hand, either one, whatever you feel the most comfortable with. I'd love to hear what you think you would do with the tough I don't care one.
And if I may, Jeannie, maybe just also have them provide examples of any situations that they've had.
Yes. I'd love to hear it.
Share one and see what.
Mm-hmm. Yeah, so, I'd love that if anybody's willing to do that.
In the chat, Elaine said, I hear I have other children. I don't need.
So what would you say in response if they say, I don't need extra support, I'm experienced?
I typically say, and I love this what you're presenting. Thank you very much. A lot of information. I typically just say, well, every child is different, you know, have different needs, and this is just better to communicate with your child and better understand them so that you can support them, you know, and this is not just like for your children, this is also for you to stay healthy, support that you may need that may come up, you know, in the future, you know, so an extra layer of support for you. You can learn something new, you know, take advantage, free, you know, so those kind of things.
Yeah. Yeah. Does that tend to work?
Yes. Yeah.
Yeah.
It does. It helps.
Yeah.
And then I also mentioned about their own childhood. Like I mentioned, like, and then I bring myself into it. I say, you know, my mom had 6, 7 of us, and we were all different, you know, and she had to deal with us differently. And sometimes, you know, one was more challenging than the other, and it was really helpful for her to get some support as well. So
yes, and to sign up for it on the front end, so you're not scrambling later on.
Yes.
Yeah, I would agree. My thought was also every child is different, but also every pregnancy and postpartum is different. Her body is different and her mental state is different with this child than it was with her other children, just because she's a different person now, right? So going back to like every postpartum experience is different. And so you might not think you need support right now, but something unexpected might come up with this baby or for your own mental health that you're not sure of. And so it's better now to just like get the extra resources while you can.
We have another comment in the chat box. They say, I already know about the program. The community, Wilmington community staff informed me about the program. If I need help, I'll go to the community of Wilmington to get support. They provide breastfeeding support too. So that would be a response that a mom would give.
Okay. What is the Wilmington community staff?
I think it's like another community resource program.
Oh, so kind of like I have other support.
Yeah.
Oh, okay. Okay, I'm going to open it up to you guys. What would you say if they said that?
I think just letting her know, this is Liliana from Welcome Baby at White Memorial, by the way, just letting her know that we're not just about breastfeeding, even though we are all educators on that. It's more about like any topic that comes up for them, like the main topics that may come up, like maybe this child's extra fussy or wants to be more attached to her, or maybe it's something with her other children adjusting to this baby. So just trying to figure out like other things that come up when she's home that she may need support with. Sometimes it works, but usually it does not. I think once they've made up their mind and they're at the hospital, they're tired, they haven't slept.
Yes.
They've like, this is not the time. They want us to enroll them later. Like, can I sign up in a week? I'm sorry. Unfortunately, our program works different. And also letting them know that there's a nurse that can go visit them. Other programs don't typically have that.
Yeah, that's a huge selling point. And the fact that they come to you, I would stress that out. Like I would stress like you don't need to go there. The fact that you guys are offering in-home support, to me, that would have been a lifesaver for me, like personally, because I remember even with my first and knowing nothing about breastfeeding, they're like, oh, well, you can go to this breastfeeding group back at the hospital. But like, one, you have to be recovered enough to drive. And then you're a new mom, you're like lugging the things around and you don't, or you are scared. You don't want to go in front of all these other moms who like, you know, there's a comfort level and convenience factor, I think, in the in-home aspect. So I would really like stress that. So yeah.
I have a question. During my hospital visit, I noticed like mom that have a history of marijuana use or positive marijuana. I noticed that like I would say like 90% they declined the Welcome Baby program. I just like want to ask like other HR like what is your experience in connecting like engaging with mom with history of marijuana and positive marijuana to motivate them or encourage them to sign up for the Welcome Baby program.
So you're posing the questions, right, to the other HLs?
No, I think she's getting your insight on what would be any recommendation or insight if because she gets clients that have used marijuana during the pregnancy. Yeah, and she finds that a majority of them don't want to be part of the program. So how do you encourage them, motivate them to join the program?
Yeah, that's kind of a tough one, just because I don't know what the correlation of like their substance use is. I mean, typically if they're having substance abuse issues, there is an underlying mental health component to that. So I would maybe go through the back door in that way, as far as like if it's known that they've used or are using or will continue to use, let's say like, you know, the education about you know, safety and health for the baby and how the program will help their mental health or get them the resources needed so they can find other coping tools. Again, that's, I guess if they'd have to be motivated, right, to stop the substance use, which may or may not occur. But I was going to just turn the question also back on what any of you others who are experiencing this, do you have any stories about women who do struggle with substance abuse and their willingness to do this or to sign up? No. That's a tough one. Anything else with the I don't care one? Any other examples or advice for each other? So you guys talk to each other because you're more of the expert of your job than I am. If what has worked in this kind of profile of somebody who's kind of surly or angry or tough or.
I can share a little bit. And which something that's helped me is sometimes when you do say, well, I already know about the program or I was in it before. I don't know if I need it now. If I notice that hesitancy, I ask them like if there's any questions that they have about it in that moment, if they had any like what did they hear about it? Because sometimes they just say, I just heard about it, but I'm not sure what it is. Then I ask them, well, is it okay if I share with you? And then I do tell them what it is. And then they say, and then I do mention, I know you've been in it before. You mentioned you've been in it before, but a lot of things have changed, especially now after COVID. There's a lot of more resources that the staff can provide you with. And just it like I said again, if anything comes up differently, they can provide support for you. So I mentioned that, and then I just also tell them that if they have other children that are, you know, of certain age and they need assistance or resources for them, that we have programs for them as well. So I mentioned that this is not just about your health and the baby or you and baby or breastfeeding. We have so many other resources, even that your family member can, you know, benefit from, you know. So I kind of make it more into a wide spectrum, not just, you know, Welcome Baby kind of thing.
Yeah, it's for the whole family.
Yeah.
As they address.
That's helped me. So hopefully that'll help somebody else.
We have another comment in the chat box. So they say a lot of moms are overwhelmed with all the ins and outs. So sometimes following up with them the next day helps.
Yeah, was saying if you're like in a not great mood person, you can just say, oh, it sounds like you're needing something else right now, so I'll come back. I'll come back. I'm sure it's hard on you guys on your end to try to get that cooperation sometimes. Why don't we move on to the silent one? Because that was another popular one. So sort of the shut down, depressed, maybe weepy. Can you guys put in the chat or raise your hand? What have you found to be helpful to kind of maybe break through that barrier or form a connection with that particular kind of mom? Just wanted to ask you guys before I gave some ideas. Can I just jump in?
I think we can give them a few minutes. I know they have many stories, so
I know I'd love to hear the stories.
Yeah.
These are all hypotheticals for me.
Yeah. And like you mentioned, they are in the front line, so do want them to learn from one another and share their story. So let's give them another minute or so.
I think going in from the back end, like you said, where you don't necessarily are going in right away to sell the program, but just introducing yourself and asking how they're doing and how was your night? And oh, I see you have really pretty flowers in the room. So asking something where you're not starting with, I'm here to sell you a program and see if
Yeah.
you want it. Just, asking about how they're doing and how was their night. And wow, you've been through so much in the last 24 hours.
Yeah.
How are you feeling? And then seeing if they can start to come around like that.
I love that because I think like as new moms, they want to be seen, even if they're acting like they don't. But recognizing like, oh, you've been through a lot, like just something like very warm like that. And like, oh, I see, commenting about the baby or oh, you've had visitors or whatever it is. I would also like, one question might be like asking like, oh, what are you looking forward to when you go back home with the baby? So there's nothing to do really with the program, but it's to kind of see if this person is, not that you have to diagnose, but maybe you can draw out from behind the wall that they're behind of like, yeah, what are you looking forward to when you get back home? Maybe in this scenario, you turn to, if there's a partner in the room, I would involve the partner in the discussion too, and ask how things have been. If she's not talking, maybe the partner will. Does anybody have any stories or scenarios with sort of more silent people or sad? They just look sad.
So we have in the chat box, these moms are challenging because they are hard to read. Sometimes they minimal eye contact.
Yeah.
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 And then we have someone else in the chat box said, I like to ask about their birth story, praise their efforts in nursing and how that makes her feel. I'll ask the partner, what's their favorite part of their baby so far? I like that too.
Yeah. Yeah. Those kind of questions that are kind of just neutral. And kind of tapping into seeing if there's some positive experiences happening or not. I think the whole like hard to read, minimal eye contact, or just kind of shut down. I think just saying something as simple as like, hey, like if they're like, they don't even know how to answer the question, how are you? Right. I think even just saying, yeah, it can be hard to name what you're feeling right now because so much has happened in the last 2 days. Your whole life has changed, right? Like It must be overwhelming. So I get that you may not even know how you're feeling. So just again, validating that they don't know. um, and then you can lead him into like, you might have a better sense of how you're feeling or what your needs might be when you get home. And that's when the RN visit will, an RN visit can happen when you have a better sense of what your mood is or what your needs are. So I think again, just normalizing, like, it's okay if you have no clue how to answer my questions. Like, if you don't know what day it is, that's okay. Yeah. I'm curious, do you guys feel like a time pressure with these women? Like you feel like you have to rush it, and so it's harder to like kind of slow down and be more warm and chit chatty? I don't know.
Like most of the time, like you mentioned, like at the hospital, at the postpartum, they're very busy, like with like so many people going and in and out, like patient, doctor, nurse, nutrition, cleaning,
Mm-hmm.
hearing test, blood test,
Yeah.
pediatrician. So there's a lot of going on. So sometimes we have to go back and forth like 3 or 4 times because
Mm.
they really tired, they are in pain, so it's a lot
Yeah.
going on. Yeah.
Yeah.
We have one hand up. Elaine.
Right. Can I share now? Sorry.
Go ahead.
So yeah, I think for me, time it is pressure right now. I'm on the floor solo, so I'm a one little soldier. So it has been challenging. Our hospital census has gone up, so there's about 10 to 15 patients on the floor every day. And so I'm trying to like prioritize, okay, who do I go see first? Who's prenatal? Who's NICU? Who's, just dissecting and just trying to see who's gonna be a priority, aside from pending rooms and, so on. So I feel sometimes guilty that I'm not able to spend as much time in a room with those moms and provide education, provide as much support as I would like to. I'm just like thinking, okay, I got to get to my next room. I feel like I'm cheating them out of something, but then I feel reassured by saying, you know what, I'm going to leave you in great hands. You're going to be with the nurse next. We're going to see you as soon as possible. She's going to go over this and that. And I like to take the Welcome Baby book inside with me. And I kind of go through the tabs really quickly. And I show it to them, and they, kind of glance at it really quick. And then I also have a demonstration of what they're going to be receiving of those incentives. So that kind of perks them up a little bit, and it helps them. But I can't like really spend a lot of time. And I explained to them, I'm so sorry, I can't spend a lot of time with you. I wish I can. If I get a chance tomorrow, if they're a C-section, I'll try to come back to your room and just check on you. And I've done it. So, and that's really self-rewarding too. So it's really nice. But yeah, sometimes it's crunch time and I gotta go. Yeah. So
Yeah.
the pressure is on.
Yeah. Yeah, I like that. I think that's why I kind of put some sample reassuring statements that you could, and maybe you just go in assuming that they're probably feeling all kinds of things. Just assume that they're feeling a range of emotions. And you can just say like, wow, this must be really overwhelming, whether it's your first baby or your sixth baby. Every birth is overwhelming, and just kind of assume and like, and we, some concerns that might pop up for you, we have resources, and lead in that way. But if you can just already validate this is hard, you're not alone, you can get help, you're doing a great job, and hanging in there with all these people in and out of the room, it must be nuts, like kind of, you can use some humor. So I think if you can kind of cut to that, the validating statements and those encouraging words of reassurance, that might help soften, like just lower their defenses. Because all of these things, all of these things, the anxious, the silent one, the I don't care, those are all defenses. And they're just trying to cope. They're just trying to survive so that they can get home with their baby. Or maybe get a nap. And so I think any kind of like even short statements of warmth can lower their defenses.
As soon as I walk into the room, I really thank them for letting me come in. You know, that's the first thing I do. Thank you so much for, you know, letting me come in. I know this door is a revolving door and I'm just another person you're talking to. You know, I appreciate time, you know, and then I go on. But yeah, they're exhausted.
I know. Yeah.
We have another comment in the chat box, which I think it's a great one too. So Emma says, sometimes going back the next day to check in on them after they have enrolled helps to encourage following up with Welcome Baby. And I do see here a lot of families don't answer the phone calls of the next staff. So I think this strategy, I think it just validates that you know, someone else is going to come see you. We're here for you. We're here to support you. So I love that, that strategy.
Yeah. Yeah. And they've likely forgotten who has come in and out a lot, and having a friendly face that they remember can just solidify that connection of like, oh yeah, this is going to be my support. They represent my avenue for support. For number one, the anxious one, do you guys have any stories or advice for each other of how to approach a mom who's like highly anxious in the moment? She might actually be an easier sell, right? Like, because she's already showing you signs of outward needing support, like that might be easier. But what can be, I think it could be hard too to keep them not distracted. I don't know, do you guys find some moms distracted and like they don't care what you're talking about, they just want to focus on whatever problem they have in the moment?
For me, for example, one of the moms was super anxious because the baby was not well. So when I come in and I introduce the program and then they agree to enroll, I always just tell them, if we can start at any time, the door's open, when lactation is ready to pause, let her come in, help you out, and then I can always come back. And I always keep reassuring them, I can always come back if you have to use the restroom, if you need whatever you need, I can always pause and I can always come back. And that kind of gives them a sense of, okay, we're doing this together. Because a lot of times, for example, when the baby hasn't ate and they're like, I'm expecting lactation, I can't talk to you now. But like knowing that lactation's busy with somebody else and they're gonna come back later, just showing them that she will be here when she comes in. I will step aside.
Oh,
I think you broke off a little bit, Emma.
Yeah, I couldn't hear the last part.
I said that just kind of helps them feel a little bit more calm and then be present in the visit until lactation comes in.
Yeah. Yeah, I think the key for anxious moms is I love that team approach that you said. Like, I'm here with you. You're not alone. We're on the same team. And honoring that, like, okay, she's currently worried about the baby being fed. And so we're going to reassure that we're going to address this problem, right? I think also just kind of helping them get centered to the present moment, that just goes a long way with helping somebody who's anxious. Like, even just, you can even just observe like, oh, it seems like you know, it's really worrisome when the baby's fussy. Like if they're like, why is the baby crying? Why is the baby crying? You know, and just that they notice that you notice, if that makes sense. That you're picking up. You're not just coming in with a script and robotically trying to sell them something, but they know that they're being seen and heard. Another line that I like to use with like anxious moms, if they're kind of in a frantic place, you know, like if they're like, I don't know what the baby needs, I'm so confused, right? Like, or this and this and that. I just say like, of course you don't know. You just met your baby like 2 days ago, you know? Like, and I remember that being told to me as a new mom, and it like completely changed my perspective, because there's this, again, this myth that you're automatically supposed to know what you're doing the moment the baby's born, that you're automatically supposed to have some magical mom intuition. And then if you don't feel it come upon you, that something's wrong with you. And so I think just saying, of course, you just met your baby. Like, it's going to take some time to understand your baby and your baby to know you. Like, so just kind of almost, again, normalizing that the anxiety is centered on not knowing, and normalizing that they're not supposed to know can help ease a lot of that worry. And that there's people who do know who can help.
All right, Jeannie, it is 3:20, so you can go over the resources and maybe open.
Yeah, the resources are just, I know you guys are going to get this. These are just websites for you. You don't necessarily, you know, more for you to like, if you are more interested in knowing more about stuff. So Postpartum Support International, they have a lot of free resources. They actually have free online support groups for moms and dads. So that's just a really great resource. They also have lists of therapists on there too that are connected. The Blue Dot Project is kind of an awareness about, they have a lot of the statistics and research about postpartum depression and anxiety. And then the Policy Center for Maternal Mental Health is more about what laws are going into effect, and even laws of like how hospitals should center and support the mom, and those kinds of things. So that was just like for more information if you're interested.